discrete area that we're going after. But similar technology, similar approach.
Okay. Now, forgive me if I mispronounce this medication. I use metoprolol daily to contain my AFib extra when I exercise.
Sure.
I expect that over time I'll need more. What are good guidelines to determine when to consider an AFib ablation? I've already had 2 SVT atrial flutter ablations, and only AFib remains, according to my doctor.
Yeah. So this is very common. You know, patients usually start out and are diagnosed with atrial flutter. Probably at least 50% of the people who experience atrial flutter will later on in their life develop atrial fibrillation. So she has read the book.
Yes.
Metoprolol, which is a beta blocker, is usually the first line treatment that we use for atrial fibrillation. After metoprolol fails, we usually start an antiarrhythmic medication, which she should either consult her cardiologist or an electrophysiologist, if there is an electrophysiologist who's in her area, in order to get further treatment. But what I tell patients about an ablation is if there's a drug that does not have a lot of side effects that works for them, then they should continue on that drug. But the moment that the drug becomes ineffective, or the moment that their frequency of atrial fibrillation increases, then that's the moment we need to pull the trigger and do the ablation. You know, we've talked about it. There's complications that can occur with this procedure, so it's not something that we want to do for everyone. But we do want to do it in the people who need it, and I would say those people would be people who have failed at least one drug or have side effects from that medication.
How would blockage in the carotid artery affect whether or not a person was a good candidate for an ablation?
Yeah, usually you're going to have that sort of risk corrected before you'll undergo an AFib ablation.
That would be first.
Correct, right,
Okay.
because that's life-threatening. You can have stroke complications so we want to correct that first. AFib, even though very symptomatic, is not a life-threatening condition. So definitely the carotids would need to be taken care of first.
This person touches on something that we've talked about before, but one thing that came to mind for me. Please talk about how you measure or determine success or freedom from AF. Is long-term monitoring warranted? If so, how do you cope with patient compliance? And I guess I would add to that, do you rely on a patient coming back to you and saying, I'm experiencing this again? I mean, is a lot of it communication from the patient?
Well, it's interesting. We know one thing that atrial fibrillation ablations do is it decreases the symptoms that you have for atrial fibrillation. So there are some patients who had atrial fibrillation and were very symptomatic, then have an ablation, and then no longer feel their atrial fibrillation as much, although they may still have it. So that was a very intelligent question that person asked, and that was the question of monitoring. And so in certain patients who were concerned that they're not feeling their atrial fibrillation, we then use monitors. We typically use a 21-day monitor where we will monitor you continuously for 21 days.
You wear something?
You wear something, okay. Yeah. It's a little bit cumbersome, but the information that you get from that monitoring is important for us. And so in those patients, we will use long-term monitoring. Yeah, okay. I would recommend that.
Okay. Now, do you approach the access via any other route other than femoral groin region to ablate? And I think we did touch on that a little bit, or maybe I remember reading something in the literature that there might be another route.
Not for the majority of the You can place some through the right internal jugular, so that would be through the neck, but that would be one catheter, and we need multiple catheters for an ablation with atrial fibrillation, so it's going to be the right femoral and left femoral vein.
There are some what we call epicardial ablations, which are ablations that can be performed from small incisions in the ribs and then going from the outside of the heart as opposed to the inside of the heart. Those, although they're called minimally invasive, are still more invasive than what we do from the leg.
Okay. Just a couple more questions here for you. How far in advance are patients taken off of their medications? And I'm assuming this person means medication for AFib prior to the procedure.
It depends on the half-life of their medication they're on. So the electrophysiologist who's performing the ablation can then look at the medication. Drugs such as amiodarone have very, very long half-lives. So I don't even like those drugs to be on anywhere near the ablation, where other drugs have shorter half-lives where we can pull them off a week before.
Okay. All right. Doctors, this has been fascinating, and I know I've learned a lot, and I can tell by all of our good questions and the intelligent level that people have approached this by, that people are really interested and learning about something important. Again, we want to mention that Our Lady of the Lake is unique in this region of the country in what we offer in terms of the AFib ablation, right?
That's correct. That's correct.
We're so happy to have had you, Dr. Kenneth Savello and Dr. Andrew Smith. We appreciate your time. And when you see your patient, please thank him for allowing us to have those cameras in there. He was a big part of this, and give him all of our best as well.
Thank you.
Thank you so much. And we want to thank all of you for participating this evening by sending us your emailed questions. Remember, if you would like to review a part of this, if you missed something, or you'd like to look at the whole thing all over again, you can certainly do so. This webcast will be archived a little bit later this evening. You can look at it again and for a long time to come by simply clicking on the OR Live website. That's or-live.com. Also on the website for Our Lady of the Lake Regional Medical Center, OLORMC.com. For all of us here at Our Lady of the Lake Regional Medical Center and the OR Live staff, I'm Margaret Lawhon. Good night from Baton Rouge.
Thank you for watching this OR Live webcast presentation from Our Lady of the Lake Regional Medical Center in Baton Rouge, Louisiana. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care. OR Live, the vision of improving health.